We're going to go ahead and get started. I wanted to welcome everyone to tonight's webinar. I am your host and moderator, Dr. Lauren Levine. Even though my picture's on that screen there, I have a really easy job tonight, which is to just do some housekeeping with you, make sure everything's running smoothly, and introduce our speaker. As usual, whenever we do a webinar with GoldenDent, we'll talk about them in a minute, we pack to the gills. Typically, we had close to 1,000 people registered tonight, and I see a lot of you are logging in right now. I'm only going to speak for a couple of minutes. I want to make sure that Dr. Kosinski can talk for as long as he would like to. As usual, most of you have been on these types of webinars in the past, so you know the way the format goes. On your screen, you have a little GoToWebinar control panel. You can type in your questions as you think about them. We don't normally get to the questions until he's done with his presentation, which is typically around 45 to 55 minutes, give or take. And then we try to get to as many questions as we can. In almost all instances, we have more questions than we have time for, and I apologize ahead of time for that. I know some of you have burning questions. We usually tend to get them in the order that they come in. Sometimes I'll combine them. I can see all the different questions that come in, so I'll do my best to make sure that as many concepts are handled as possible. In the next couple of days, a couple of things will happen. You should get an email with a link to download this webinar, which has been recorded. So don't worry if you can't stay towards the end or you get distracted. It's not a big deal. You're not going to miss anything. During the webinar, Dr. Kosinski will be demonstrating a number of products he uses for these procedures. A number of these are exclusive to GoldenDent, and as always, I wanted to thank GoldenDent for their sponsorship of this webinar. We've been doing webinars with GoldenDent for a number of years now. If you are in dentistry, you know about their commitment to ongoing dental education. At the end of Tim's presentation, Kurt Lawler will come on from GoldenDent. He almost always has some fantastic special pricing to offer, and also talk a little bit about the educational opportunities that are there. As part of that, if you are attending this webinar live, you will get a continuing education certificate. GoldenDent hands those out. It takes a while. Every time we do these webinars, I get at least a dozen emails within the first 24 hours. Where's my CE? How do I get my CE? So I'm going to mention it now. We'll talk about it at the end as well. They do send the CE out. It can oftentimes take a few weeks when there's 1,000 people registered. So give us some time, but we will handle that. And with that being the case, without further ado, I wanted to introduce tonight's speaker, who needs no introduction, and that's Dr. Tim Kosinski. Tim is an affiliated adjunct clinical professor at the University of Detroit Mercy School of Dentistry. He serves on the editorial review board of Reality and the Michigan Dental Association, and serves as the associate editor of the National AGD. He's a past president of the Michigan Academy of General Dentistry. He got his DDS from the University of Detroit Mercy Dental School and his mastership in biochemistry from Wayne State University School of Medicine. He's a diplomat of the American Board of Oral Implantology and Implant Dentistry, the ICOI, and the American Society of Osseointegration. He's a fellow of the American Academy of Implant Dentistry and received his mastership in the Academy of General Dentistry. Dr. Kosinski has received many honors, including the fellowship in the American and International College of Dentists and the Academy of Dentistry International. He's placed over 14,000 dental implants, God, that's a lot, and published over 190 articles on the surgical and prosthetic phases of implant dentistry. He's been a contributor to several textbooks. He lectures extensively around the U.S. each year, so look for him at some upcoming events you may be attending, which includes tonight. So Tim, we're thrilled to have you here and looking forward to tonight's presentation.
Well, thank you, Lauren. It's always an honor and a pleasure to have you host and be a part of your programs. I always find them very informative. I listen to a lot of the ones that you do. But tonight's topic is one that is really close to my heart. I just presented at the American Academy of Implant Dentistry Central District meeting, and the amount of information that's out there is just amazing. Dentistry is going so fast. So enough said about that. Let's get to some practical information that we can all use in our daily practices. As many of you know, I'm just a general dentist from Detroit. We do place a lot of implants. We have a great practice. I'm very proud of that. But I also am very fortunate, Lauren, to be able to share some of my information. I like to say that I was blessed with great mentors throughout my career, and it's really awesome at this stage of my of the profession to be able to give back some of the information that works really well for me. Quite briefly, our objectives tonight, hopefully, are really clear. We're gonna learn some of the what I like to call atraumatic extraction techniques that help preserve bone and soft tissue in preparation for dental implants. Dental implants obviously is one of the most hottest techniques in dentistry today. It's certainly the most financial rewarding and professionally rewarding technique that we use in our practices. You know, Lauren, that our patients are coming to us as general dentists requesting this treatment. And you know, people out there that have toothaches or missing teeth or hate their partials or dentures certainly are going to the internet and searching those topics, and what's coming up are dental implants. And it's our job as professionals to not necessarily sell this technique to them, but rather to educate and instruct the public onto the benefits of what can be done. And I'm a big believer, being an Academy of General Dentistry person, that belonging to the Academy of General Dentistry is very important for general dentists. They are the only group that truly advocate us as general dentists. So, and dental implants is an important part of what we're going to be doing tonight, and hopefully throughout your career. Again, it is very rewarding. But to be able to properly place implants, we also have to understand and be able to do atraumatic extractions or minimally traumatic extractions. Maintaining bone is very, very important. Bone is gold to me in my practice. And so I just want to demonstrate some of the techniques that I use every day, literally every day in my practice, that and instruments that I would not practice without. So we'll learn those techniques that I use very, very efficiently and effectively. And then we're going to talk about some of the faster, easier, and most efficient bone grafting materials that I use in my practice. Now, Lauren, what I like to say is, you know, there's 100 ways of doing what I'm going to show tonight. But all I can do is show you what works well in my hands, what works predictably in my hands. I like to say that I can grow bone nearly 100% of the time, but that means following certain protocols and procedures. So you too, even after a quick hour webinar tonight, should feel comfortable with some of the knowledge that I'm going to provide, some of the instruction that I'm going to provide. But I'm going to focus on a certain number of materials that, again, have worked very, very well, regardless of your grafting experience. I know most of us that are listening today take teeth out, but we also know that taking teeth out can be very difficult. It can be very challenging sometimes. I know, because I see a lot of patients with root tips that are left in the jaw, and you wonder, how can anybody leave a root tip? And that's because it's very frustrating. It can be very challenging. And we have a myriad of instruments to try to remove teeth efficiently and effectively, sometimes without luck. And hopefully I'll be able to share some of my techniques that make you more efficient and predictable. I'm going to show you some of the grafting techniques that I use, and especially some of the grafting techniques that are very low cost to you as the professional, and you can therefore pass on the savings in these materials. I do a lot of research. I do a lot of histologic evaluation prior to my implant placement. And what I'm going to show you today, tonight, are very, very, very predictable techniques and very predictable materials, regardless of your experience. And being able to, as I mentioned, being able to extract efficiently and effectively, and then to salvage the sockets is very important. You know, as professionals, when we remove teeth, bone is going to shrink. It's going to shrink down and in the lower jaw and up and in the upper jaw. So trying to maintain that bone height is very, very important, especially if you want to consider dental implants. I know this is not a dental implant program, Lauren, but I often ask, you know, attendees, you know, those of you out there, 80%, 85% of general dentists are not placing implants. And I always say, why? Why are you not placing implants? And there's a lot of reasons. One of the biggest reasons is the fear of harming the patient, the fear of the mandibular nerve, fear of the sinus area. And some of those fears are brought upon us because teeth are lost and bone shrinks. So being able to feel comfortable and explaining to your patients the importance of maintaining bone, not only today, but in the future, is an important lesson. So we have to learn how to explain grafting procedures to our patients. Oftentimes, you know, again, I ask an audience, you know, you're taking teeth out and you know about grafting, you understand grafting. Why aren't your patients accepting it? And the answer normally is financial. Oftentimes dental insurance doesn't cover it. Dental insurance doesn't cover it. The patient doesn't want it. But again, you need to be able to, as professionals, instruct and educate your patients onto the benefits and why grafting is an imperative part of our practice today. And if we don't effectively graft and maintain bone, placing implants in the future may be a much more invasive and a much more expensive procedure for those patients. So we're going to talk about why grafting is so important and how to get those predictable results. We're going to talk about the different materials, specifically about allograft materials. Now, allograft materials are materials from the same species, human bone that's been harvested and sterilized. All our materials today are very, very strongly FDA controlled. They're very safe and efficacious to our patients. Some of our patients, for a number of reasons, religious reasons, ethical reasons, do not want human remains in their body, and I can understand that. So we're also going to talk about alloplastic materials, which are synthetic materials made in a laboratory that I find still to this day very, very, very effective. We'll talk about the different types of allograft materials out there. Another very, very important part of my program tonight is reflection design or flap design in suturing. That is as important as anything we do in practice, and being able to maintain soft tissue and get predictable results are important, especially in the aesthetic zone, in the smile zone, in the anterior maxilla. To be able to grow bone, we must protect the materials from invagination of epithelium. And to do that, we will talk about the different membranes that I use and that are critical to the success. Some of you out there, the hundreds of people that are listening now, that maybe have taken a grafting course, have tried grafting with mixed results. Maybe you understand that it's important to graft, but you go back and it's mush, it's not good. Well, that's a technique problem that we're going to try to alleviate tonight. So let's have some fun. I hope, as general dentists, most of you are doing most of your extractions in your practice. I think that it's something that, if learned properly and practiced well, can be a very financial rewarding technique or treatment for our patients. I know in Detroit especially, and probably around the country, I assume, the most valuable asset our patients have is their time. People just don't have time to come back and forth or go to different offices for treatment. So being able to provide a wide range of services in a short amount of time is a very, very great way of building your practice. What are your results with extractions? Are you having a hard time? Are they predictable? Are you leaving root tips in routinely? Are you staining the underarms of your scrub tops and the collars of your scrub tops because of the challenging extractions that we're doing? Well, hopefully we're going to show you how to alleviate some of those issues that you're having. And again, maybe some of you are doing grafting procedures with mixed results. Let's learn some grafting techniques that are going to be so predictable and provide you a certain level of confidence in providing this service and dental implants to your patients. So we want to get phenomenal results, nearly 100%. When I do a grafting procedure, I expect to have bone growth in a very short amount of time, in 4 or 3 or 4 or 5 months, depending on the socket site. You don't think your patients can afford it? Well, let's make it affordable for them, whether that insurance covers this procedure or not. And I'm going to show you techniques and procedures that are very, very cost efficient for you and will be affordable to your patients. To be able to place implants, I'm a big believer you must feel comfortable extracting and preparing the site, and that means grafting. It's an important part of implant dentistry today. So you need to get involved. We're going to use the term atraumatic extraction or minimally traumatic extraction. We're going to show you things that work well in my hands as far as grafting goes. Again, this is not an implant course. I'm not going to promote any particular implant type. Rather, I commend you for listening, and also for those of you who aren't involved, to get involved. We have many, many wonderful programs out there that I'm involved with that are easy to find, where you can actually get hands-on experiences with your patients. And Kurt at the end, through GoldenDent, has wonderful programs at our University of Detroit Dental School where you'll be able to master some of these techniques on live patients. And I'm a big believer there's nothing better than learning on live patients. So let's get started. So, you know, we have a tooth that's deemed non-restorable. Don't we all love posts in dentistry? I probably do more implants on teeth that have posts than anything else. And we know that when root canal treatment is done, the teeth can become brittle. The posts that are used to build the tooth up so that we have something for the crown to grab onto can act like a log splitter, so to speak, and fracture the root. And here we have a tooth, a molar tooth, that was deemed non-restorable by our endodontist and required extractions. We do an extraction, atraumatic. We're trying to maintain bone. Bone, again, is gold to me as in preparation for dental implants. And I'm going to focus on really 2 procedures today. We're going to focus on 2 materials, allograft and alloplastic materials. We're going to focus on membrane use and how we do that. We're going to focus on flap design or reflection. But we're also going to talk about 2 different types of bone defects when we take a tooth out. I'm going to call one of them a 4-wall defect. And what I mean by that is all walls are intact: facial, mesial, distal, and lingual or palatal. Those are fairly easy to treat, and we'll demonstrate that quite readily. However, in our practices, the facial plate of bone is often lost. We want to minimize that, obviously, but sometimes it's not possible because the facial plate may be very, very thin in our patient. But I can teach you in this next 45 minutes how to repair a facial defect quite efficiently. So hang on to your hats and let's get going. When I take a tooth out, I always take a radiograph following the extraction. Even if I'm absolutely sure that I had the entire root taken out, I want to make sure. I do not want to leave any root tips for the next practitioner down the road. I will graft the procedure, and the different graft materials will objectively appear differently on a periapical radiograph. Some will look opaque and some will look less opaque or more radiolucent. And here you can see we have a mixture. It's rather more opaque than it was before. Remember how a socket is going to heal throughout my program today. A socket heals physiologically from the apex towards the crest. So we're always going to get more mature bone growth at the apical portion than we are at the crest. And after a quick 3 months, you can definitely see radiographically how we have a change. The appearance of that extracted site has changed. This bone is not completely mature, of course, but if we prepare the site for a dental implant, I don't need to be completely mature because I'm going to allow the implant to integrate also. As I mentioned, I do a lot of histology. And what I will oftentimes do is I will take a core sample, a trephine sample, and do a histologic evaluation of what I perceive has occurred in my grafted socket site. And without being a histologist or taking a lot of time here, the magenta color that you see in this cylinder that I recovered from that grafted site is bone. It's bone that is turned over The purple is less mature bone, and it takes time for all this to happen. So I'm very, very confident that I can grow bone in these sites very, very efficiently and effectively, to the point where I can place an implant. Again, I can place an implant atraumatically. This is a flapless procedure immediately post-operatively. No bleeding, very little post-operative discomfort for the patient. My patients are given ibuprofen for discomfort, for pain relief. And over time, after the implant integrates for a period of time, you can see I can very predictably load the implant, and this happens to be a screw-retained prosthesis, zirconia bruxer crown, and you can see how over a period of time the bone matures to a high level. You will get these results too. I am nothing special, just a GP in Detroit that's perfected the techniques that work very well in my hands, and you too can get the same results. So let's talk about bone very briefly. I don't want to spend a lot of time. I want to spend more time clinically, but we know that all skeletal bone demonstrate volume stability over time, except our dental alveolar bone. And why is that? Because the dental alveolus is very labile in the absence of loading. What does that mean? We all understand this, right? We've seen this. Patients that lose teeth, we make a denture. Over a period of time, that denture has to be relined or rebased. Why? Well, the plastic didn't change. It's because the underlying bone changed. And that's because it's not being stimulated. Dental implants is a very important part of dentistry today, in that it helps minimize future bone loss, big selling point to your patients, minimizes future bone loss, and allows us to have stability or function with whatever prosthesis we choose to use. Bone grafting is possible, unlike other tissue, because it has the ability to regenerate. What happens? We put our synthetic material, or our grafted material, or allograft material, and we get a physiologic response. Osteoclasts will invade those sites, start eating away those crystals, and immediately stimulate osteoblasts to lay down new bone. I like to use the analogy in my practice when I'm talking to a patient about the procedure. If you've ever broken an arm, and most people know somebody that's broken a limb, what happens? You're in a cast for 6 weeks or so, and the bone heals. It actually heals stronger than it was before. So that's what's going to happen in the mouth. If we don't graft, we know that the bone is going to change. How much, how often, how fast is difficult to determine, but it will change over time. So grafting, if explained to the patient well, is a treatment that is fully accepted by our patients. The biologic mechanism, the physiologic mechanism for bone grafting are osteoconduction, osteoinduction, and osteogenesis. Let's just go through these definitions really quick. Osteogenesis is the ability to create viable bone cell development, and the only material in the body that will do that is the patient's own bone. We can draw blood from the patients. We can create protein-rich plasma, protein-rich fibrin to help stimulate bone development through osteogenesis, but that's not what we're going to focus on today. That could be another program, Lauren. Osteoinduction is the ability to stimulate those cells capable of formulating bone cells like bone morphogenic proteins and platelet-derived growth factors, etc. Some of our allograft materials, our cadaver bone, is osteoinductive to some degree, and we certainly can get osteoinduction through our PRP and PRF treatments that have become all popular again. Osteoconduction, which is the case with all allograft and all alloplastic material, is simply a structure that is created to support or scaffold bone development, meaning it's like concrete in stone in concrete. It acts as a scaffold for bone development. Osteoinduction with allografts, not all allograft material are osteoinductive, but bone morphogenic proteins can induce stem cells to differentiate into osteoblasts. And depending on how the allograft material is processed, some of it is acid wash, which removes the mineral and exposes growth factors and proteins to help include new bone growth in the procedures. And then osteoclasts release hydrochloric acids to break down the bone, releasing stem cells for new bone formation. So you need to know, you know, as you're purchasing product, what you're intending to do, how fast you want the turnover to occur. Let's go through some techniques. So we have a tooth here, a tooth that was sent to the endodontist. If we're fortunate that our endodontist is right next door, and we have options to the patient. And the endodontist actually provided options to the patients: root canal therapy, maybe apicoectomy to remove the persistent granulation that's occurred, or extraction, graft, and future dental implant. And many of our patients today, especially in our general practice, are electing to be treated with an extraction graft and a future dental implant. So we have a tooth that's deemed non-restorable, and we want to remove this tooth. So I challenge you that are listening to today, how do you remove this tooth now? Well, I would probably say most of you would take some type of instrument, a periosteal elevator, a periotome, and go around the periodontal ligament. Then I assume that you would take a elevator, or we now use luxators, to see if you could give movement of that tooth. Some of you may section, knowing that there's 3 roots here, section the palatal and the mesial and buccal root. It's a time-consuming process, and oftentimes takes a myriad of instruments. And you know that not only are you traumatizing the socket area, you're traumatizing the patient, because most of you at some point are going to take a conventional forceps, grab onto it, squeeze as hard as you possibly can, and wiggle that tooth out. Figure 8s, buccal, lingual, mesial, distal, however you were trained. It's traumatic to the patient and can be traumatic to us as the dental practitioner. Taking teeth out can be difficult. What I'm going to ask you to at least evaluate is my favorite product, something that I would not practice without in my practice, is the GoldenDent Physics Forceps. And Kurt at the end, I know, has some great specials. This is an instrument that consists of 2 components. The beak, or the shovel-shaped edge, will engage the lingual or palatal aspect of a root 1 to 3 millimeters subgingival. This is the working end of the instrument, and it'll allow the tooth to be luxated up and out of the socket following the curve of this specifically made instrument. The little green thing that you see on the top we call a bumper. This is not the working end of the instrument. It is simply acts as a center of rotation so that this tooth can again be luxated up and out of the socket. It is not holding the facial plate of bone intact. It is not aiding in anything other than allowing for a center of rotation. It's a series of four instruments, and these are my favorite: a upper anterior, upper left, upper right, and a lower universal. You need all 4 to be able to effectively treat the entire mouth. So in my practice, I may say, Trish, we're going to take out tooth number 3. She will bring me 1 instrument. She will bring me the upper right physics forceps and place the green bumper on it for me. Another set of instruments, these are the molar series instruments for those teeth that maybe we don't have a good purchase point on the lingual or palatal aspect, and we would like to remove the tooth from the facial aspect towards the lingual or palatal. A little bit different design, but another fine instrument that allows us to remove teeth in more challenging situations like the posterior mandibular molar areas. So you can see, as I said, we have the beak, which is will engage the lingual portion or palatal portion of a tooth 1 to 3 millimeters subgingival, and the bumper and a bumper guard. The bumper is simply a center of rotation, which allows the tooth to be moved up and out of the socket following that specific curve of the instrument. So here we're simply sliding on these silicone bumpers. These are disposable. I do not reuse them. They're they're very inexpensive, and I'm sure Kurt has a special on them also. And it allows for a little cushion with the instrument. And you can see the instrument in use. So I am simply, oftentimes I will not luxate this tooth, nor will I take a periotome or periosteal elevator to go around the tooth. And I'm simply engaging the beak on the palatal aspect of this tooth. Now you must have a purchase point. If the tooth is elliptical in some respect, then I will take a 557 surgical burr and flatten the root. I'm not damaging bone. Bone is gold to me. especially the interseptal bone, which is really important in the aesthetic zone. So I engage the beak, I put the bumper as high up the vestibule here, and I am not squeezing this instrument. I wish they didn't even call it a forceps. I wish they called it a luxator, because you're not putting pressure by squeezing the handles. You're simply rotating your wrist in this situation towards the left eye. Very, very effective. We're creating tension on the palatal aspect of this root, which is resulting in a physiologic response. The body is going to release an enzyme, which is going to break down the periodontal ligament. What's holding this tooth in place? The periodontal ligament. If we destroy the periodontal ligament, the tooth is going to pop. You're not going to hear a pop. It's going to pop up and out of the socket. You can see how it's following that arc of rotation. The instrument is not intended to remove the tooth in total. Rather, it's intended to luxate the tooth up and out of the socket. I will then take what we call a tooth delivery instrument. I'm simply grabbing on. Now at this juncture, this is maybe a 1.5 minute procedure. And I'm simply removing the tooth in total. So I'm not sectioning, and I'm certainly not damaging the interseptal bone in this area. A very effective, very efficient, and very atraumatic or minimally traumatic to the tissue around the site, to the patient, who oftentimes isn't even aware that I took the tooth out. I did several patients today, and the patients look at you and they go, you're kidding, right? Because they're used to extractions being very, very traumatic to them. If it's not traumatic to the bone, if it's not traumatic to the patient, it's relatively atraumatic to the doctor, and that's what I truly appreciate about the instrument. You can see these divergent roots, and we're able to remove this tooth quite efficiently in a couple minutes, very efficiently, removing the infected tissue in total, and not having to work all that hard. In this situation, one of my favorite osteoplastic materials is called Osteogen, and you can get this through GoldenDent. It is a material that is a bioactive calcium apatite material in a bovine Achilles tendon matrix, and the material actually mimics the organic and inorganic components of physiologic bone. The bovine Achilles tendon is simply a collagen carrier, and it's prevents invagination of epithelium. Tissue, when we graft a site, there's always a race between bone growth and epithelium invagination into the socket. I said earlier that bone heals or integrates from the apical portion towards the crest. The epithelium will go from the crest towards the apex, and it's a race. Well, epithelium grows up to 10 times faster than bone, so we must protect, in most situations, our grafting material from invagination of epithelium. And how do we do that? We do that with either a membrane or with this synthetic material, this calcium apatite. The bovine Achilles tendon carrier actually prevents epithelium invagination into the socket. The epithelium will follow the path of least resistance. It can either go in or on top of it, and it will simply choose to go on top of it. So this is a material, and I don't know exactly what reward Kurt from GoldenDent is going to give you today, but it's a material that's maybe a $40 or $50 plug that is very, very simple to place into the socket. So what do you charge the patient? For those patients that you want to graft, you don't want the sinus to collapse in that area, right? We know if you remove a tooth root, the tooth root acts like a tent pole holding up a circus tent. If you remove the tent pole, the circus tent's going to collapse. So placing a graft material and protecting it is really, really important for a future implant. It really makes socket preservation easy and affordable. There's two sizes, a large and a small, and I would talk to Kurt and his team to see what kind of special they can give you and get a wide variety of both types. This is how it's packaged. We'll undo the package, and it's simply like a plug. It's not like a collagen plug that you can get very inexpensively. The collagen plugs are normally derived, again, from a bovine dermis, but these collagen plugs, inexpensive ones, resorb rather quickly. They turn into snot essentially in a very short amount of time, anywhere from a few days to 30 days. And they're good for clotting, but they're not good for bone growth. When we're grafting, we need to protect that graft from invagination of epithelium for a minimum of 6 weeks. These are important numbers to remember. And so a material that's only going to last a few days to a month is not going to cut it. So anyways, let's go back to the Osteogen plug. You can see it's rather firm. It's not like a styrofoam exactly. And you can see what I did was I cut the edge and I made it look like the root of the tooth that I just extracted. Cool photograph. And again, we've talked about this. We're going to plug this material into the sockets. Now, you could cut this into 3 pieces and then put the 3 individual pieces in, but here I'm showing off a little bit and made it look like the socket. We're going to place it into the socket firmly. We're not condensing it like amalgam, rather than we're condensing it firmly, and then we're going to protect it with a couple sutures so that it doesn't fall out. Now, it's important that you tell your patients that this graft material, this synthetic material, calcium apatite made in a laboratory, is white in color, as is our allograft material, as is our membranes. You want to tell them that. It's very important because someone's going to look in their mouth and they're going to see something white and they're going to think it's pus or infection, and they're going to poke it or play with it. It's supposed to be there, leave it there. Again, remember what I said, epithelium grows 0.5 millimeter to 1 millimeter a day. So if you have an opening, we do not need primary closure with these materials. Let's say we have a 5 millimeter or 6 millimeter opening. You know it's going to take about 12 days for that to close over completely. So just be aware of that. The material is somewhat radio opaque so that you can see the transformation, as I showed in that first set of radiographs, how the bone will turn over a relatively short amount of time. So we have the tooth taken out, and it's very, very important. This technique is important. We must curette, 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 curette. You want to remove any granulation from the socket site, any purple blood. Red blood is good. And you can see I'm just picking out that huge granulomatous mass that was in that socket. You want to clean all of that out. Yuck. And then here I'm simply taking my Osteogen plug to site, and I'm slowly letting the blood absorb into it and pushing it into that socket and plugging it, not like amalgam, not crushing it, but firmly to the crest of the ridge. Now I want to protect this material, and I'm simply going to suture, place a couple sutures here in this site. And I want you to see how I'm suturing. I'm taking my reverse cutting needle, and I'm going from the crestal portion, and I'm sliding it over the top of the graft to the facial, and doing the same on the lingual. That way I'm not going to grab onto the material. And you can see I just put a couple interrupted sutures to hold it in position. Take a radiograph post-operatively. You can see that the material has some opacity to it, and over time you can see how that will convert. Another tooth, I'm going to run through this because I think you get it now. We have a tooth that's deemed non-restorable, mandibular tooth, and again I'm going to take my universal lower physics forceps. I'm going to engage the beak onto the lingual portion of this tooth, 1 to 3 millimeters subgingival. I'm going to place the bumper as far down the vestibule as possible to act as a center of rotation, and I'm simply going to rotate my wrist. I'm not squeezing this instrument. I'm simply rotating my wrist towards the shoulder. The tooth will lift up and out of the socket. The instrument is not intended to remove the tooth in total. Rather, I'll take a tooth delivery instrument and remove the tooth in a matter of minutes, relatively atraumatically. My techniques are very consistent. I'm going to curette, 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 curette. We have a major socket. I'm going to take my large Osteogen plug. Doctors, it cannot get any easier than this. Cannot get any easier than this. You're taking a product that's $50. You did the extraction. You're going to charge that out. You're going to take this material and you're going to maintain that bone. so that in the future, if you do want to place an implant, you're not going to be as concerned with bone loss and the mandibular nerve. I'm going to pack it firmly to the crest, firmly. And GoldenDent has a really nice series of extraction instruments and grafting instruments you may want to look at. Kurt, I don't know if you have a special on them, but I would challenge you to do that for the attendees today. We have such a big group today. I'm really, really impressed. So you can see the material is placed to the crest, and my suture techniques are always the same, kind of using my reverse cutting needle, sliding over the top, and we will allow this material to integrate over a period of time, allowing me a matrix. So you can do this. It's affordable. It's, you know, it's a $50 material as opposed to an allograft and a membrane, which could be $200 to $250. You do not need a membrane with it. It is a graft material. It's not just a collagen plug. And I'm telling you, I get incredibly predictable results. I feel very comfortable when I graft that I know that I can place an implant in 3 or 4 months, very, very predictably. And I've done a lot of histology to prove that. Remember, if you have questions, type them in there, and then Lauren will get to them at the end, if that's okay. So I mentioned earlier, we're going to focus on 2 types of defects. We're going to talk about the forewall, where the facial wall is intact, and we're going to talk about where the facial plate is missing, which concerns us as dentists, right? We all see that invagination of the facial plate. It makes conventional ponic design challenging, and certainly makes our implants challenging. So let's get into those very, very efficiently. The literature today is focusing a lot on allograft materials, and when we have a facial wall missing, the technique of choice in the literature is using an allograft, human bone, and then a membrane. You must correctly place a membrane to protect an allograft material. You don't necessarily need a membrane with the osteogen calcium apatite material. So, and there's a lot of materials, as I said earlier, we don't have time to go through all of them. We're going to focus on the allograft material. We're going to focus on the osteogen materials. So here, another tooth that's deemed non-restorable. How do you want to handle this tooth? It's in the aesthetic zone. In my hands, I'm going to go ahead and take my physics forceps. One instrument, I'm engaging the palatal aspect of this tooth, placing the bumper as high up the vestibule as possible. And here, in this situation, without squeezing the instrument, I'm simply rotating my wrist, towards the nostril. You can see I am not squeezing. The one handle is in the palm of my hand, and I'm simply creating tension on the palatal aspect of that beak. That's creating energy, and I'm taking my tooth delivery, and I'm able to remove that tooth very, very atraumatically. Take a radiograph, doctor. Let's make sure there's no root tips there, and curette. Curette, curette, curette. But let's see what happens. We do have a defect. We have a defect at the apical portion where there was a fistula. We can't ignore this, doctors. We do have bone on the facial aspect at the crestal portion, but we have a defect at the apical portion. So I'm going to reflect. And we don't have a lot of time talking about my reflection techniques, but I guess the best analogy that I can use is if you pretend you have a number 10 envelope, you know, those long white envelopes, and you lift the flap and you blow into it. You can see I'm elevating the tissue so that I'm going beyond the defect. I have to be able to see the defect, but I'm not making any vertical incisions. Doctors, if we do not cut into mucosal tissue, you will not have a lot of discomfort with our patients. If you cut in the mucosa, you're going to get a lot of prostaglandin and histamine release, and it's going to hurt and it's going to swell, and your patients aren't going to be happy. If you refrain from cutting into mucosa, our patients' discomfort can be controlled quite readily with an anti-inflammatory like ibuprofen. So here I've taken here's a small osteogen plug, and because I had an open defect on the apical portion, I placed a membrane, a resorbable membrane, a long-lasting membrane, and there's different types out there. There's collagen membranes, from porcine peritoneum. There's bovine collagen matrix. There's even synthetic materials, and I know Kurt with GoldenDent, a material that I really like is called EpiGuide. Great products. But again, we need a membrane that is going to protect the graft for at least 6 weeks. So I need a membrane that's going to last at least 6 weeks. These are all resorbable membranes. It's rare that I use a non-resorbable membrane. This membrane is used with osteogen, but I thought you said, Tim, you didn't need a membrane, but I had a defect on the facial wall. So I'm using the membrane to protect that facial wall from invagination of epithelium. I'm covering it over. It's a very passive technique. You can see I'm not forcing this membrane. I'm suturing. And we had placed an implant immediately into that site, and it will heal over a period of time. Another area, you can see a root canal treated tooth. It looks like there was a access problem. Post was put in. Endodontic failure in this situation, in this molar tooth. And if we look at our CBCT again for education, you can see that facial plate of bone is extremely thin. So there's a good chance that you're going to fracture that plate in removing the tooth. It's not that we did it wrong, it's just that that facial plate is very thin. So here's another GoldenDent instrument, a very nice instrument, periotome, and the blue coating is a plasma vapor deposit, which makes it very, very strong and scratch resistant. Again, look at the GoldenDent grafting and extraction products. They have a really fine set of instruments. We have separators, we have a bayonet that we use, and which allows me to go between the tooth root and the bone level, a periotome. But again, I went back to my GoldenDent physics forceps, allowing the tooth to come up and out of the socket without squeezing the instrument. The tooth is luxated and taken out with a tooth delivery instrument. Atraumatically, you can see that there's no facial bone on that facial aspect of the tooth. I'm going to curette, but remember, it was so thin, it was paper thin in that CBCT. When you curette, you can see that we definitely have dehiscence there. So we have to reflect this tissue, and we have to be able to repair it quite effectively. So this is another GoldenDent instrument. It's called an Orban knife, which I use to go around the teeth. I am not making vertical incisions. I am not incising into mucosal tissue whatsoever. I'm very gingerly elevating, and you can see both palatally and facially. I've controlled the tissue. And here we're going to use our GoldenDent Goldos particulate. It's an allograft material. It's osteoinductive and osteoconductive, which helps us to accelerate bone growth. I'm going to take this sterilized material and wet it with sterile water or sterile saline. Never use anesthetic to wet your graft. Anesthetic has a very, very low pH, and it's going to inhibit bone growth. So some of you may have used an anesthetic in your grafting and not gotten the results you want. That's one of the reasons. Here I place my implant. Again, this is not an implant course, but we need to repair that facial aspect. And the grafting, the membrane material here was a long-lasting membrane called EpiGuide that GoldenDent can provide you. It's a synthetic material, so it's not a bovine Achilles tendon. It's not a porcine. It's not an animal product whatsoever, and it's worked very well for probably 10 years for me or more. It's a polylactic acid material. It is resorbable. It's hydrophilic, and it will maintain the site, protect the allograft from invagination of epithelium. It is site specific. Smooth side towards the bone, the roughened side towards the tissue. You can see we place this membrane very passively, but as dentists, for those of you general dentists out there, we know that we have a tendency to force things. We have to feel comfortable reflecting tissue so that the membrane can be placed passively. You don't want to be tugging and ripping and tearing. If the membrane comes out before 6 weeks, then the case becomes unpredictable. I don't know if you're going to get bone growth. So when I do my grafting procedures, I can tell you that I get bone growth because I take the time to make sure that my membrane is properly placed, passively placed. You can see I'm not holding it. There's no forces holding this in position. Suturing, as I mentioned, from the crest towards the facial, towards the crest towards the palatal. And I simply suture the site. You can see it's white. I don't want the patients to think it's pus. I did not get primary closure here. I have attached gingiva on the facial aspect for regeneration. Epithelium will grow over that membrane in a very short amount of time, maybe a couple weeks. It may take a couple weeks for it to close over completely. I see my patients in 7 days to remove the sutures. These are vicro sutures, and you can see my immediate placement of my implant in that site. Now there are 2 teeth. Deemed non-restorable by our endodontist, and we're going to atraumatically remove these teeth. And it looks like we did a pretty nice job. You know, it looks good. But what are you going to do next, doctors? You're going to curette. And this is the nice set of GoldenDent instruments that I use just about every day in my practice. It's the instruments that I feel very comfortable with, and I'm sure Kurt will have a special on these products today. Later today. We have a facial defect. I did not create the facial defect. It's because of the fractured root. So I'm taking my Orban knife and I'm going around the teeth and making a reflection. You must feel comfortable making this envelope flap without vertical incisions, both facially and palatally. I'm exposing the site. Doctors, if you can see it, you can fix it. No different than endo access. You're not going to take 20 minutes trying to find that 4th canal or 3rd canal. If you have good access, you can see it. If you can see it, you can fix it. Here we're taking our gold os from GoldenDent allograft material. I'm wetting it. Taking my membrane, my EpiGuide membrane, cutting it to site, and you can see my implants are in position here. The technique is really irrelevant, and you can see that there's no facial wall, but I can grow a facial wall. I'm taking my allograft material, packing it firmly and passively placing my membrane over the site. My suturing technique are very specific, and you can learn these techniques in our courses at the University of Detroit Dental School through GoldenDent. You can see I did not get primary closure because I want attached gingiva to form on the facial aspect. After it heals, I'm going to go ahead and take my impression of my implants and make 2 nice zirconia Bruxer crowns. Anterior tooth in the aesthetic zone. Let me back up for a second. I apologize. So look at the crown in the lateral incisor. I know it's not really pretty, but I want you to see the final result and be able to compare. The lateral incisor was deemed non-restorable. Look at the tremendous amount of periodontal bone loss on the distal aspect of this tooth. We have a fracture because of that post, and that's where the periodontal defect ends. We're going to atraumatically remove this tooth. You can see when I create tension on the palatal aspect of the root, you can see pus emulating from the facial aspect of the gingiva. We're going to remove this tooth atraumatically, taking my tooth delivery instrument. Now I have to evaluate the site. Curette. I have no facial wall, doctors. I think we all agree. We have no facial wall here. So what do we have to do? We have to fix it. We can't hope that it's going to go away. If we leave it, that bone growth is going to invaginate in, which is going to make placing a dental implant impossible in the future and or necessitate the need for a much more invasive block graft to try to establish width of bone. I'm taking my allograft material from Gold Os. I'm wetting it. Taking my EpiGuide membrane, which is a long-lasting membrane that will protect the allograft from invagination of epithelium. I'm taking my Orban knife, making an envelope flap, and to expose the defect. Very, very important now. I know I'm going very fast because we're running out of time. When we place our membrane, when we make our reflection to place our membrane, we must reflect beyond the defect. To place your membrane, you must place that membrane a minimum of 2 millimeters beyond that defect. Doctor, this is non-negotiable. You have to feel comfortable seeing the defect completely and placing your membrane to protect that allograft at least minimally 2 millimeters beyond the defect, apically and mesial distally. Otherwise, the case becomes unpredictable. I said I can grow bone 100% of the time. It's very technique sensitive, but certainly within the realm of every person listening here. I made my osteotomy. I'm threading my implant in position. You can certainly see that I have no facial wall whatsoever around this implant. I'm going to put a cover screw. I'm going to place my membrane at least 2 millimeters beyond the defect, and that becomes my new wall. I'm then going to take my GoldenDent allograft material and pack it firmly and passively rest my membrane over the top onto the palatal aspect so that I'm completely protecting that graft. I'm suturing all of the technique that we've demonstrated. You can see I'm not going to get primary closure, but that 5 millimeter area is going to heal up very quickly in 5 to 10 days. You won't even know that we did anything. You can see the implant in position. It's ideally placed, but you can see the radiolucency around that implant. Here the patient wore a flipper appliance. And after 4 months of healing, you can see what type of tissue response we got. We definitely have a facial plate of bone. We definitely have a healthy attached gingiva, and we're able to create a nice zirconia abutment with margins right at the gingiva and a fairly decent zirconia aesthetic crown. Obviously not cosmetic dentistry perfect, but functional for this patient and giving the patient a great result in a proper amount of time. We're coming to the end here. Another tooth that's deemed non-restorable. We're going to remove it using the GoldenDent technique, using the physics forceps, removing the tooth atraumatically, removing the cyst around it, even with that little curvature of the root. I'm going to curette. I'm going to graft this site. And because we had a facial wall, I'm just going to thread right into that graft material. And that graft material will protrude and fill the defect because my implant is actually a little bit smaller than the defect itself. So I finished pretty much on time. I went a little bit over, and I certainly want to answer the questions that you may have. We covered a lot of material, about a half a day of material in an hour webinar. And I know Kurt from GoldenDent has some great specials for you. Try these products. I love this company. They're Detroit-based. They're family-owned. These are good people. They warranty their products. If you're not happy, they want you to be happy. They have a great team behind them. They have a great team of practicing dentists, great teaching programs on live patients. So become a part of our family, and we hope to see you at one of our future programs. Lauren, thank you. I'd be happy to entertain any questions as you need.
Thanks, Tim. We do have about a dozen questions or so, but we're going to switch things over briefly to Kurt from GoldenDent. Kurt, as you and I both mentioned, is going to have a great special to offer as well as talk about some of the educational opportunities that they provide. So, Kurt, take it away.
All right, perfect. Thanks, Lauren. I'll keep this hopefully quicker than normal here this evening. But my name is Kurt Lawler from GoldenDent. As Tim mentioned, we're a Detroit-based company. Our brand and clinical solutions are actually going back a third generational dental family that began here in Detroit in 1936. And we operate under the principle of providing simple, predictable, and unconventional dental products. And that's kind of what we focus on. So if you're not familiar with GoldenDent, thank you for joining this evening. So we always give a special on these webinars. I know a lot of dentists that join our webinars on a regular basis each month. And just as we do in the past, we are offering a discount on any of the products or techniques that were discussed this evening by Dr. Kosinski. And it's 15% off. So it's actually a great deal. It's better than we do for the trade shows or even any of our hands-on programs. The webinars are always going to be the best discount. So I guess I suggest take advantage if you are on the webinar this evening. So physicsforceps.com is where you can find our products, and Amplify Dental is where you can find our educational programs, which are focused on extractions and grafting, which I'll go into here in a moment. But the discount code is it's 4WAL15 for 15% off discount. And I'll come back to the slide here at the end. Since the specials are good, we do them just kind of a quick flash sale, so to speak. We do them for 24 hours, and it's good through June 12th, which is the end of the day tomorrow. If you wanted to take advantage of any of those, it works on any product on our website. So we focus quite a bit tonight on the Osteogen plug. It really is a great product with a promotional offer. It's $42 a bullet. And as Dr. Kosinski mentioned, you do not need a membrane with this product. It's been a very, very popular product for us. We've offered this now for, I think it's going on maybe the 3 or 4 years now. I think we've had this product, and our customers are very, very happy with it. So if you haven't tried it, I definitely would suggest looking into it. It comes in a box of 5. You can get 5 large or 5 slim. There is not a mixed pack currently on the market. The large is the more popular size. If you have not tried it, I would suggest the large. So the separators, obviously in order to use the Osteogen plug, most of the times you're going to want to have a 4-wall defect. I know we did show some cases this evening where you can also use it when you do have a defect with a membrane, but you do have to have an atraumatic extraction for the most part for the product to be effective. So how do you do that? The separators are a good way to start. A lot of doctors like to use this prior to the physics forceps. We keep it simple. I know there's other products on the market where they have maybe 8 to 10 of these in a kit, and we believe you really only need these 3. These are going to be just as effective, and they're not expensive. They're $74 an instrument. These are good to use in advance of the physics forceps. We also have an instrument on there. I actually need to get one of these to Dr. Kosinski. This is a good instrument. It's got an elevator type handle on it. We call it the wedge. It's also a nice pre-step to the atraumatic extraction process. Has a comfortable handle where you're going to basically be pushing apically and wedging between the rigid hard tooth surface and the bone, and working your way around the tooth prior to using the physics forceps. Physics forceps, it came out in 2007. I guess it should probably say 12 years now instead of 10. But this is our signature product. What started our business in 2007. It's been it's a great success, since 2007 and still today. It's been 12 years already, which is hard to believe. But this product, there's 4 instruments in the set. I won't get into too much here because I think we already covered this pretty good this evening. But there is 90 days to try the product. So that's one great thing about it is, as I mentioned, a lot of our products and our company is, our dentists, and they understand what junk drawers are. We want you to be happy with products. So if you're not happy with it for any reason, which is not very common, we have a lower than, I think, a 1.5% return rate over the last 12 years, which is great. If you get the concept and the technique, and as Dr. Kosinski mentioned, don't treat it like a forcep. Most people do get the concept and technique, but there's just a little bit of learning curve, and it also comes with a great training DVD. And as long as you use them gently, they are effective. They're an elevator. 90 days to try them. Same with the molar series. We didn't cover these, but they're the same technique and concept. They allow you to go back to what we call hard to reach second molars and erupted thirds. So these aren't as, these aren't going to be used as much. If you haven't used our instruments before, I would recommend the standard series is a good way to get started. These are more of like an accessory to the set of 4. They go further back into the mouth, but you lose a little bit of your leverage with this product. It's not as easy to use as the standard series. So our allograft, there's a lot of allograft in the market. Like I said, we tested and evaluated our products for a long time, like we do with any of our products before we offer them to the market. There's a lot of allograft, but we do believe our allograft has some unique characteristics, which you can read about online, and it's fair priced. If you're using a different allograft brand, we'd encourage you to give GoldenDent's Gold Os product a try. We do stand by it, and we've had great feedback. Our 2 membranes, EpiGuide is the one that I know Dr. Kosinski's used for a number of years. He actually introduced us to this product, and we've been teaching in our courses ever since, and we've had great success with it. So it's a long-lasting resorbable membrane, and that's what's important, as was discussed this evening, for the techniques. We have some collar guides and some other membranes too, but the Epi Guide would definitely be the one I would probably recommend. BioViva, we didn't discuss this evening, but this is a great alternative to gel foam. If anybody maybe already has some of our products or haven't tried the BioViva yet, this goes very well with the extraction aspect. If you have a patient that is maybe bleeding a lot, or you're not going to do a specific graft or third molar site, this is a really great hemostatic gauze that controls bleeding almost instantly. And I think the pricing on it's only like $60 a box of 20 of them before the discount. So very affordable. If you're, like I said, if you're using gel foam, we've had a lot of customers switch over to use our BioViva. This is our graft kit. It's not an expensive kit. It's nice to keep it all together. Dr. Kosinski already showed this evening. This is what he helped us develop and design. This kit's it's less than $500, so it's very affordable. They look nice, and you know, they're high quality instrument. The reflector's another a newer instrument for us. This is just great for reflecting full arch cases and reflecting the tissue, during a full arch case. It just has a nice handle to allow you to properly reflect large areas of tissue, get it out of the way if you're doing like a bone leveling, so to speak, or some other procedure where you want to have the soft tissue out of the way. It's another instrument to take a look at if you haven't visited us lately online, or if you're an existing customer. It's something that we have that's new. This is totally off topic, but I'm going to mention it just because it's a great product, and I'm trying to share this with anybody that's doing class 2 restorations, which is pretty much, you know, most offices are using some sort of a Tuppermeyer or a sectional matrix system. This is a new brand for us, Wagotrix. We launched this back in October of 2018. And again, it's off topic this evening, but I just wanted to make you aware of it, to take a look at it. It's really a great product. The whole kit's $125, which is, as I say here on the slide, it's pretty much the price of other companies' rings. So you get 35 of our rings, which is really the most unique aspect of the system. It's designed to be disposable. So maybe some doctors on this evening have a ring that looks like this. We took this picture only after 10 days of using this popular ring, and it looks very gross. There's composite on it. They're hard to clean. Your staff could throw them away. They can break. They can spring off. We've really taken a hard look at that and developed this ring here that's purple in color. And they're designed just to throw them away. So you throw away your wedge, throw away the matrix band, just go ahead and throw away the ring with the system. And you really are going to get that perfect tight contact, because you don't know how many times maybe you've used your metal ring, maybe they're starting to wear out. You don't think you're getting the separation you're still looking for in your ring, and you know you're going to get that every time with the Wagotrix because it's a brand new ring. So I just wanted to mention that, and then this is our composite that goes well with that. It's actually zirconium infused. You can take a look at that online. I'm not going to get too off track here with what I'm mentioning. Lastly, our CE courses. These are just some photos at UAD here in Detroit, and these are just some past course photos that we've done recently. This is the facility. It's live patient, so as Dr. Kosinski mentioned, it's a great way to learn. You pair up, you work in your own operatory with a partner, and we never really seem to have a shortage of patients. We have a great, in our 2-day program, first day where we go over all of the products and really detailed lecture, and so you're prepared for the live patient component on day 2. We have a course this weekend coming up, but it's actually sold out. We've got 30 doctors for that one, and coming up this weekend, so it's going to be a lot of work. And our next one is called AMP2. Looks like we have 7 seats open as of the time I wrote this, which is coming up in August. And again, you can learn more about that at amplifydental.com. And with that said, I guess I'll wrap up. Hopefully I didn't go too long, and we'll get to the questions. And I appreciate everybody's time this evening.
Thank you, Kurt. Tim, you ready? We got a bunch here, so we're going to try to get to as many as we can.
Absolutely, Lauren.
Okay. Are there any situations where you wouldn't use a physics forceps? Anything, for example, if you got a dilacerated root where it may not work in that situation?
Oh, that's an awesome question. So in mandibular molars, I routinely just section the molar and remove the 2 roots as if they were individual bicuspid sized teeth. I just do that routinely. Mandibular molars, I rarely section. Ankylosed teeth, it's not going to work on an ankylosed tooth because it's like there's no periodontal ligament to break down. When we have dilaceration of root tips, if you use the instrument slowly and we break down the periodontal ligament, even if there's a significant curvature in that root, I was just talking to a friend of mine today from Florida who said that she was able to get a tooth that had a big curvature on it quite efficiently using the physics Forceps. So those are really, I use it routinely pretty much for every situation. Be aware that the facial plate in the aesthetic zone in the premaxilla can be very paper thin, and oftentimes it is a challenge to remove those teeth and maintain the facial plate of bone. So no, I pretty much use it wherever I can. Are we still there?
There?
Yeah,
I
I'm
think
here.
I lost the audio there for a second. Okay.
Oh, okay.
If extracting an actively infected tooth, is grafting typically not recommended?
No, that's a great question. I do not place an implant in a aggressively infected site. However, you're going to curette, you're going to remove as much granulation as possible, remove purple blood, granulation. That is a site to graft. And Lauren, I guess the analogy that I would use is if you've ever had a hangnail on your big toe and you're at Disney and it's the most horrible experience, it hurts so bad, right? And what do? You soak your foot, you clip the nail, and 5 minutes later you forgot that you even had a problem. The body's an amazing thing. When the source of the infection is removed, the body will heal. So I will graft a site that was infected. I just will not place an implant immediately in the site like that. That's a great question.
Okay. Now you had said that typically it's about 3 to 5 months for bone growth. How long after the OGP do you wait before placing the implant?
What's OGP?
Yeah, I'm not sure what they're talking about as well, but so I thought
it might be.
Okay, so if I extract a tooth and I graft, I can look at it. I'll bring the patient back a week later to take the sutures out. Then I'll normally bring the patient back, depending on how big the socket was. Let's say if it was a bicuspid, I'd bring the patient back in 3 months and evaluate it and take a radiograph, because I can objectively look at the radiograph and see what kind of turnover I have. Remember, we expect better growth of bone at the apical portion and less on the crestal portion. But if you're going to place an implant, Lauren, I'm going to remove that bone anyways and allow the implant to heal for another 3 or 4 months. So I don't need to have complete integration of bone. I just have to have the apical portion turned over to natural bone. So
okay.
I guess to answer the question, we're going to graft for 3 to 4 months and then place the implant and allow the implant to heal.
Okay. Speaking about radiographs, so if you're placing the osteogen graft, is there a predictable way to assess, either through CBCT, et cetera, the density of the bone present prior to implant placement?
Well, with our digital radiographs, we can often determine density, and certainly with our CBCTs, our modern CBCTs, we can determine the density of bone in those sites. Absolutely. With our typical digital radiographs, we can visualize the changeover in opacity of a socket site from very radiolucent to moderately radiolucent to more radio-opaque, and that's an indication in itself.
Okay. Are you still irrigating prior to osteogen plug? If it's near the sinus, are you still curetting aggressively, or will residual granulation tissue be an issue? Are you using any type of clindamycin on the plug prior to placing it?
Great question too. No, I mean that putting antibiotic on our grafting material kind of comes and goes in all the years of my practice. I just don't do that. I've purchased tetracycline and all those things over the past. I get great results. I do not do that. I do not put antibiotic in my grafting materials. I do curette aggressively. Okay. I guess your concern is that you're going to penetrate through the Snyderian membrane and create an access. I think it's important that you remove the vast majority. In that one case that I showed, there was a big snot of granulation. You got to get that out. You just can't leave it, because then the case becomes unpredictable, or the healing itself may take longer.
Okay. And by the way, OGP was the Osteogen plug. I had a few people.
Oh, okay.
Right. That's what they meant.
Gotcha. Cool. All right, got it. That's a new one.
How do I ask this question? Since I know sometimes people are discussing their own fees. What in the Detroit area, if a qualified GP was putting in an Osteogen plug, what's the typical type of fee that they charge, and what code are they using?
Great. I don't know the codes. I apologize for that. Kurt can provide that, I'm sure. We normally have the codes, in this presentation. So that can be provided through GoldenDent, the codes, okay? So let's look at it. When I was in school, and Lauren, maybe when you were in school, we were told, well, you charge, what do you charge for a crown? 4 or 5 times your lab bill, right? Or the procedure. And I think that's still a very safe way of doing it. If a procedure is taking you 15 minutes, you're charging for the extraction. I'm talking about grafting and placing an implant, and it's a 15-minute procedure, and your material is $40 to $50. Is it fair to charge 4, 5 times that? $160, $250. I don't think very many people, the public, is going to balk at that. I know my patients don't, and we're in Detroit. Okay, Detroit was the hardest hit economy in the country. I think the education that goes along with that, in telling the patient that this is important, that we don't lose any bone, because it is gold to us. It's very important that we maintain bone. That is a very fair fee. But your grafting fee, when you're talking $250 of product in allograft and a membrane, or $200, then your fee is, I'm trying to get everybody to do the math themselves, Lauren, if you see how I'm playing that game, without coming with the number. I think 4 or 5 times your material fee is a very fair fee, and an acceptable fee to your patients. How about that? Is that a good answer?
Oh, yep, I think it's great.
I'm going to run
I know you don't.
Next.
Yeah. Now, I know you don't know the specific codes. We had a couple of questions about that, but how are you billing it out for insurance? Is it socket preservation, or are you doing it as bone graft and membrane? I mean, how do you?
It's my understanding that dental insurance is not covering grafting. And I apologize. I'm going to direct this question to Kurt. Maybe he can answer it more specifically. It's my understanding that dental insurance does not cover grafting very often, maybe 10% of the time. So it's kind of a mute point at that point.
Okay.
Yeah, I can find the codes. If my screen wasn't live on the screen, I would find it right now. But I'll add it into the email that we send out afterwards with the replay link.
Thank you, Kurt.
Perfect. Yeah, thank you. And there was a few questions about rewatching this, and the answer is yes. Within usually about 24 hours or so, Kurt and GoldenDent will send out the link that you can download and watch the entire presentation at your convenience. When you're using the Osteogen plug, is there a specific suture material that works best in your hands?
Can you repeat that, please?
When you're for the Osteogen plug, is there a specific suture material that works best for you?
No, again, we all have our favorites. I use Vicryl in my practice. That's my go-to suture because it's resorbable, long-lasting resorbable. It may last 3 weeks. I usually bring the patient back in a week, and it resorbs to water. So it's very, very minimally inflammatory. Really, whatever suture you want to use is fine.
Okay. Is there any risk of putting an Osteogen plug into a socket area where there was a root tip fracture? It's an area that will not be restored by an implant, but the dentist wanted to at least have some support and minimize the chances of a defect there. So any risk of doing something like that?
I hate that question because I see root tips left all the time. I would prefer that the doctor remove the root tip. It just becomes unpredictable, Lauren. I don't know the answer. I don't know if you're going to get a residual infection there later. But I hate root tips left in the jaw. I just hate it.
It's okay. Now, with the a couple questions here related to the technique of primary closure, and wasn't in the past, didn't you used to place like a membrane and then place like a cover screw through it to stabilize the membrane? And what type of primary stability are you getting before you graft those immediate extraction sites?
Great question. So it's imperative here that, number one, the membrane be used to protect an allograft. Number one, you have to. Number two, it has to be placed passively, meaning you can't force it. Number three, it has to extend at least beyond 2 millimeters beyond, minimally 2 millimeters beyond the defect. Rules that cannot be broken. And if it's done, you will get bone growth 100% of the time. I promise you that. But that's not what we do as general dentists. Oftentimes we take shortcuts. You can overlap two membranes together if you don't have, if it's not long enough. So I don't use tacks or screws very often because I've gotten pretty good at reflecting tissue and making sure that the membrane is tucked passively. I do not need primary closure. You're right. Years ago when we used Gore-Tex material, you had to get primary closure. To get primary closure on a molar, meaning you have to pull that tissue pretty taut, which means you're going to have mucosa on the facial aspect of your implants, and that's not acceptable today. I do not need primary closure as long as I'm using a membrane that's going to last at least 6 weeks. And most of our long-lasting, high-quality, like the GoldenDent products, the EpiGuide and their collagen membrane, is such high quality that it's going to last months, not weeks. I do not need primary closure. The epithelium will grow 0.5 millimeter to 1 millimeter a day over the top of that membrane, protecting the graft material. Great question.
Okay. If someone has seen a fair amount of fracturing of the buccal plate, what advice would you give them as far as the technique or case selection?
Yeah, we call this the physics forceps, and as I mentioned in the very beginning, I wish we didn't, because it is technique sensitive. There is a learning curve, and because we call it a forceps, we have a tendency to want to squeeze the handles, and in squeezing the handles, that's where the facial plate is broken. I think the GoldenDent courses at our University of Detroit Dental School, where each doctor is going to take out 20, 30 teeth, you get pretty proficient at the technique. You have to take our time. I know as dentists, we like to rush. We don't, 2 minutes is a lifetime. We can't wait 15 seconds for a curing light to turn off, for God's sake. We have to take our time and let the instrument do its work. But I think, and that's a concern that I've heard many times, Lauren. You can't squeeze the handles. It's simply creating tension on the beak, on the lingual or palatal aspect, and not squeezing the handles and allowing the instrument to do its work to elevate that tooth up and out of the socket, or luxate that tooth up and out of the socket.
Okay. This relates, I guess, to the last case that you showed. When you're doing an immediate implant, obviously you need grafting because the implant's not going to fill the volume of that socket. But aren't you typically going beyond the apex of that defect, at least a couple of millimeters to get some type of primary stability of the implant, or are you just putting it as far as you can go in and leave it there?
Yeah, the stability of our implants, regardless of the type, is in the 2 millimeter apical portion of that implant. That's where we're getting stability. So the answer to your question is yes, but no. The implant, I didn't take a lot of time today. I know sometimes we do, Lauren, on positioning of the implant. The implant is actually placed near the palatal wall. It's placed about 3 millimeters palatal to the facial aspect of the adjacent teeth. So I'm actually engaging not into the socket. That implant is not into the socket. So I'm not going beyond the socket. It's actually palatal or lingual to the socket. And that's where I'm engaging that bone. So the answer to your question is yes and no. I'm not going into the socket, so I don't have to go 2 millimeters beyond the socket. It just looks that way in a two-dimensional radiograph.
Got it. When do I get to the last few questions in the last 5 minutes? Will the allograft and a membrane also work with a two-wall defect, missing, say, like the buccal and lingual plates?
Will the allograft and the membrane work in a, well, I didn't want to focus, Lauren, I didn't want to focus on where two walls are missing, because those are much more complex, and those are really situations where in the past, a block graft, an autogenous block graft, we would take bone from the symphysis or from the ramus with bone screws. We are starting to use our synthetic materials and different type of allograft blocks to do that, but that's not really the forum. That's not really a technique for this forum. That's a little more complicated than what we wanted to handle here.
Okay. If someone say is doing an upper molar extraction, how is there a way that they can easily determine when they're still in granulation tissue versus the floor of the sinus? Because they're kind of similar.
Yeah, I mean, not really. It can be challenging, but I can assure you that perforating into the sinus is not the end of the world. The body's an amazing thing. It will heal. I know we are very concerned with the mandibular nerve and the sinus. If you got perforation of the sinus floor, what I would do is I would cut a little circular piece of my resorbable membrane and make that the new floor. Kind of place it in there and make that my new floor. Well, once the infection is gone, the body is an amazing thing. It just heals. It heals remarkably.
Okay. A couple of questions about 3-well defects. In a 3-well defect, could you possibly use an osteogen plug and then place a membrane using an allograft?
Yeah, again, I didn't want to demonstrate that too much today because yes, we are doing that. So yes, you could use an osteogen plug, but I would put a membrane on top of it as if it were an allograft material. So the answer to that question is yes.
Okay. What about using like a burr or laser to stimulate some osteogenic activity before placement of the graft?
I love using the laser. Absolutely. Yes.
Okay. Do you recommend antibiotic prophylaxis prior to extraction and grafting?
Yeah, if there's an active infection, I use a low dose of antibiotic, Lauren, and I can share that with you. If I have the ability to start the patient the day before, I would, but I use 500 milligrams 3 times a day for 3 days. So if I could start the day before, fine. If not, I'll start the day of surgery. We don't need a lot of antibiotic anymore. If there's no sign of active infection, the American Academy of Implant Dentistry, indicated there's really no reason to give an antibiotic regimen with patients that don't have active infection.
Okay. How do you quote a fee to a patient for 4-well grafting if you don't know if there's going to be a dehiscence after the extraction or wall fracture, where you would need to then use a membrane?
My fee is the same. We have my fee is the same, regardless of the material that I'm using.
Life a lot easier.
Makes it easier for me, yeah.
Your first couple of examples of sutures appeared to be in an X formation. Do you loop through the first suture with the second?
You can. I mean, suturing is a whole nother program too. That would be an interesting webinar, suturing webinar. But those were just interrupted, and I just want to hold that material in place or hold the membrane in place so the patient doesn't, play with it. So those were 2 interrupted, but yeah, you can do. There's mattress sutures. There's a lot of different techniques that you can use. But basically, to make things simple, those are just 2 interrupted.
Okay, so in a summary, in a 3-well defect, are you reflecting, then doing osteotomy, placing membrane, then allograft, and finally immediate implant?
Right. I would extract. I would evaluate curette. I would reflect my envelope flap. I would do my osteotomy. I would place my implant. I would place my membrane, place the graft, passively place the membrane onto the palatal lingual aspect, and suture.
Okay.
Great question.
We're almost at our last one, believe it or not. We only got about 2 minutes left anyways. What's the best indication for the Goldos non-particulate putty?
A putty is just a matter of convenience. When you take the particulate material and you wet it, it basically becomes like a gel. So it's very easy for me to manipulate. A putty is something that is just in a different form, which allows you to place it. It's convenience. It's what you're used to. It's a little more expensive to use it in that way. But a putty is just another application of a particulate.
Okay. I was a little confused about this as well. Did you say that you always section lower molars in extract, or is that for maxillary molars?
Never maxillary. I shouldn't say never. Rarely maxillary. Mandibular molars, I just routinely, because they're going to be divergent roots, I will section it and take it out as if they were 2 individual roots.
Okay. And for the envelope flap, how much medial and distal would you typically go?
1 tooth over.
Okay. Well,
Enough
we
so
are.
You can see it, you can fix it.
Makes sense. Well, we're out of time and out of questions. So, Tim, this was great. I mean, we do these on a pretty constant basis, you and I, and you know, unlike a lot of speakers out there who just regurgitate the same material over and over, I learn something new every time. You've always got great new cases and a great way of presenting it, and we're just so appreciative of you taking the time out on a busy Tuesday afternoon to educate everyone. So thank you so much for that.
Thank you, Lauren. You're awesome.
Thank you. And we wanted to thank Kurt and Golden Dental as well. As I said, they have been just fantastic to work with. They mean what they say what they mean. That code, the 15%, is actually typically more than what they normally do. Usually it's a 5 to 10% code, so that's a great deal. When they say it expires tomorrow, that means don't call them on Thursday and say, hey, I want the deal, because it'll be gone. But I think it's a great deal. They've got a great return policy. I'm not aware of any of our clients who have ever actually returned this stuff, but everyone loves it. But you know, you do have that opportunity. So thank you to them. We know that your time is valuable. We thank all of you for joining us. We tend to do these webinars on a regular basis, so look forward to the next one. I think our next one with GoldenDent is going to be in August, but you'll all be invited for that and given a heads up. So thanks everyone for joining us this evening, and we look forward to seeing you all in future webinars. And as I mentioned at the beginning of the webinar, if you are here live, you will get that CE certificate. We had close to 1,000 people registered, so it can take a few weeks, so please be patient, but they will go out eventually. So thank you all again, and we look forward to seeing you all on the next webinar. Good night, everyone.
Good night.